Welcome to the Deep Dive. We take your sources, your notes, and turn them into clear, useful knowledge. And today, we've got a stack of revision notes you shared with us on Duchenne Muscular Dystrophy, or DMD. Looks like you're trying to get the key facts down quickly.
Yep.
So our mission today, unpack these notes, find the really high-yield stuff, and help you get your head around the core concepts of DMD for revision or, just to understand it better.
And what's great about these notes is how they take a really complex genetic condition and break it down. We're going to connect the dots, right, from the genetics to the symptoms you see, and then how it's managed, all based strictly on the material you sent over.
Okay, sounds good. Let's dive in then. First off, what exactly is Duchenne muscular dystrophy based on these notes?
Okay, so the definition here is pretty clear. It's a genetic disorder. And the main thing is it causes progressive muscle weakness. And a key point right away, primarily affects boys.
Right, boys. And why is that? What's the etiology, the cause?
It comes down to a gene mutation, specifically a mutation in the dystrophin gene, which is located on the X chromosome.
Ah, okay, X chromosome.
Exactly. And this mutation means there's a deficiency, sometimes a complete lack, of the dystrophin protein. This protein is, well, absolutely crucial for muscle cell structure, for their stability. The notes say it's usually inherited from a carrier mother, but it can also happen spontaneously, a new mutation.
So X-linked. That makes
Right.
sense why it's mostly boys.
Precisely.
So following that, who's most at risk then? What do the notes list as risk factors?
Well, being male is the big one, obviously. Then having a family history of DMD following that X-linked recessive pattern we just talked about, and specifically inheriting that mutated gene from a carrier mother. Those are the main points in the notes.
Okay, and how common is it? What about the epidemiology? The notes give figures.
Yeah, they do. They describe it as an X-linked degenerative disease, mainly in boys. And the most common and severe type of muscular dystrophy. For the UK, the figures given are about 1 in every 3,500 to 5,000 male births.
Wow.
And for families, it mentions that sons of carrier mothers have a 50% chance of getting it, and daughters have a 50% chance of being carriers.
That really puts the impact into perspective. Okay, this is where it gets really interesting for me.
Yeah.
The pathophysiology. How does lacking that one protein, dystrophin, actually cause all these problems?
Right. Good question. How does that missing protein lead to muscle weakness? So the notes explain that without enough dystrophin, the muscle cells just aren't stable. They lack that structural support.
Like scaffolding.
Yeah, kind of. Dystrophin connects the muscle membrane to the internal structure, the actin. Think of it like a shock absorber, too. Without it, muscle cells are really vulnerable to damage just from normal contraction and movement.
Okay.
This constant damage triggers inflammation. Then the muscle fibers start to degenerate. And over time, sadly, they get replaced by fibrous tissue and fat, which, can't contract.
Right, non-functional tissue.
Exactly. And that progressive weakness affects the limbs, the trunk, and, critically, the respiratory muscles. The notes also make a point here about the type of mutation. In DMD, it's usually a frameshift mutation. It completely messes up the genetic code reading frame, leading to a useless protein.
Okay.
They contrast this with Becker's muscular dystrophy, which is milder. That's often a non-frameshift mutation where some, maybe partially functional protein can still be made.
So the type of genetic error makes a big difference in severity.
A huge difference, yes.
Got it. So thinking about a patient, what would you actually see? What are the signs and symptoms the notes highlight?
The main thing is that progressive muscle weakness. It usually starts noticeably in the legs and pelvis, proximal muscles first. So you see difficulties with things like running, jumping, even just standing up from the floor.
And there's that specific sign mentioned, right? The visual clue?
Yes. Gower sign. It's classic, the notes say. That's where the child uses their hands to sort of walk up their own legs to stand up from sitting or squatting.
Right, pushing off their legs because the leg muscles are weak.
Exactly. It really shows that proximal weakness. Other signs mentioned are a waddling gait, falling often, and just general delays in motor milestones, like sitting up, walking.
What about other physical signs? Anything else?
Yes. Muscle wasting is present, but interestingly, the notes mention enlarged calves. Pseudo-hypertrophy.
Pseudo, so not real muscle.
Right. It looks bulky, but it's actually that replacement tissue fat and fibrous tissue we talked about. Contractures are also common, so limited joint movement, especially ankles, hips, knees.
And beyond the muscles, does it affect other parts of the body?
Yes, definitely. The notes list cardiomyopathy, weakening of the heart muscle, that's a big one, and respiratory muscle weakness, which gets worse over time. Also, in some cases, learning difficulties or intellectual disability are mentioned. The notes add a few other details, too. Symptoms often appear by age 3, maybe speech delay, developmental delay, failure to thrive, sometimes even abnormal liver function tests showing up early. Fatigue is mentioned, too.
Okay, that paints a really detailed picture. So if a doctor suspects DMD based on these signs, how is it confirmed? What investigations are used?
Well, the notes say it starts with the clinical picture, obviously,
Okay.
especially if a boy isn't walking by 18 months or shows those delays or Gower's sign.
Mhm.
Early diagnosis is key. The notes stress that. For management and for genetic counseling for the family.
Makes sense. What tests are done?
The first big one mentioned is a blood test for creatine kinase.
Right.
CK, this enzyme leaks out of damaged muscle cells.
Right.
And in DMD, the notes say the levels are sky high, like 50 to 100 times the normal upper limit.
50 to 100 times. Wow.
Yeah, that massive elevation is a very strong indicator, a real red flag.
So what comes after a high CK?
Genetic testing. That's crucial according to these notes. It looks directly for the mutation in the dystrophin gene that confirms the diagnosis.
So high CK points towards it, genetic test confirms it.
Pretty much, yeah. The notes suggest CK first if you suspect it because the levels are so high. Then genetic analysis plus the clinical signs lead to the diagnosis. They also mention muscle biopsy. It shows the lack of dystrophin protein and the muscle fiber changes. Apparently, genetic testing is now mandatory after a positive biopsy, and sometimes biopsy is still needed if the genetic tests are inconclusive.
Okay.
EMG electromyography is listed, helps distinguish muscle versus nerve issues, but the notes seem to prioritize CK and genetics. And importantly, an echocardiogram to check the heart because of that cardiomyopathy risk.
Right. Got to check the heart early.
Definitely. And the notes add that genetic analysis can also identify female carriers, and it's used for prenatal diagnosis too.
Okay, that covers the diagnostic path. Now, muscle weakness can be a symptom of other things too. What else might look like DMD initially? What's in the differential diagnosis according to your notes?
Yeah, good point. You always need to consider other possibilities. The notes list several things. First, Becker muscular dystrophy. We mentioned that one similar cause, same gene, but milder, later onset, linked to those non-frameshift mutations.
Okay, the milder form.
Then limb girdle muscular dystrophy. This affects the hip and shoulder muscles, the limb girdles, but it involves different genes, not dystrophin.
Different genetic cause altogether.
Right. Then there's spinal muscular atrophy, SMA. Big one to differentiate. SMA is a problem with the motor neurons in the spinal cord, the nerves controlling the muscles. So the nerve is the issue, not the muscle itself directly. Causes weakness and atrophy.
Nerve versus muscle, key difference.
Crucial. And finally, the notes just generally mention other myopathies, other muscle disorders with different causes, genetic or acquired. So broadly, you're thinking other muscular dystrophies, other primary muscle problems, or neurological causes. Considering these helps zero in on DMD.
Makes sense. So once the diagnosis is confirmed, what's the management strategy? What do the notes say about managing DMD?
Management is complex. The notes really emphasize it needs a multidisciplinary team, lots of different specialists involved, and the focus is mainly symptomatic. Improving quality of life, trying to maintain mobility and function for as long as possible, and managing all the complications that come up.
So it involves therapy, maybe orthopedic stuff, medications.
Exactly. Physical therapy is key. Orthopedic interventions are often needed, and medications. Corticosteroids are highlighted. They're prescribed to help slow down the muscle weakness progression and keep function going longer.
Okay, steroids are important.
Yeah. And genetic counseling right at the start is also noted as key management for the family.
Do the notes talk about different management approaches for different stages of the disease?
Yes, they do. They kind of break it down. Initially, it's about getting the genetic diagnosis, counseling, getting the family plugged into specialist care, making sure immunizations are done.
Right, the basics first.
Then, in the early stage, while the child is still walking, it's about physiotherapy, maybe using orthoses like leg braces, and starting those corticosteroids to maintain function.
Trying to keep them walking longer.
Exactly. Then, after walking ability is lost, the focus shifts. Mobility help like a wheelchair, ongoing orthopedic care for scoliosis or contractures, and really importantly, starting surveillance for heart and breathing problems. School support is also mentioned.
Okay.
And in the later stages, it's about supporting increasing weakness, really optimizing the respiratory and cardiac treatments, nutritional advice, maybe respite care, and bringing in palliative care for comfort. Oh, and they also mentioned being really careful with anesthetics if surgery is needed, potential complications there.
Good point. Are there other specific medications mentioned besides the corticosteroids?
Yes, one called atalurin is mentioned.
Yeah.
It's for children over 5 who have a specific type of mutation, a nonsense mutation. The idea is it helps the cell read through that mutation to make some dystrophin.
Ah, so it tries to address the underlying problem a bit.
Kind of, yeah. The notes say it aims to improve walking ability and quality of life in that specific group.
And what about non-drug management? What else is done?
Loads. Physiotherapy is ongoing strengthening, preventing contractures. Surgery might be needed, like for scoliosis or severe contractures. Ventilatory support becomes crucial as breathing weakens things like CPAP or non-invasive ventilation, like BiPAP.
Right, helping them breathe.
Yep. Nutritional support, too, especially if swallowing gets hard. And psychological support, that's huge for the patient and the family dealing with everything.
It really sounds like a comprehensive team effort over many years.
Absolutely.
So, looking at the long term, what's the prognosis generally, and what are the major complications highlighted in these notes?
The prognosis, unfortunately, is one of progressive muscle weakness. The notes state that boys usually need a wheelchair by about age 12. And sadly, the major life-limiting factors are usually respiratory or cardiac complications, leading to death typically in their 20s or 30s.
You mentioned those earlier. Heart and lungs again.
Exactly. They are the critical systems impacted long-term. The notes list a whole range of complications. Joint contractures, making movement difficult, respiratory problems, progressive failure of the breathing muscles, leading to hypoventilation, needing breathing support, and higher risk of chest infections, cardiac problems, that cardiomyopathy, arrhythmias, GI issues like gastric dilation are mentioned. Educational difficulties, about 20% might have learning issues, according to the notes.
Okay.
And then things related to being less mobile and maybe long-term steroid use. Constipation, osteoporosis, obesity, hypertension. Weight loss can happen late stage too. And those anesthetic complications we mentioned.
It's a lot to manage. You emphasize the respiratory and cardiac issues being critical for survival. How specifically do the notes say those are managed?
Yeah, they give some detail on managing those key areas. For respiratory care, regular checks by a respiratory specialist, treating chest infections quickly, ongoing physio, including techniques to clear airways, and eventually using non-invasive ventilation, an IV, like a mask ventilator, and maybe devices to help with coughing and clearing secretions.
Proactive breathing support.
Definitely. And for cardiac care, screening early for cardiomyopathy, regular monitoring with ECGs and echocardiograms, treating heart problems and arrhythmias if they develop. Addressing breathing issues at night can help the heart too. They also note needing closer cardiac monitoring if the patient is on corticosteroids and possibly using anticoagulants if the heart function gets really poor.
So constant monitoring and intervention for heart and lungs is vital later on.
Absolutely critical, based on these notes.
Now, you mentioned the notes briefly touched on the future. What did they say about potential developments?
Just briefly, yeah. They mentioned ongoing research and development in areas like gene therapy and something like exon skipping. These are approaches that show promise for actually treating the underlying genetic cause of DMD, which is, the ultimate goal.
Hope for the future there. Okay, before we wrap up, let's pull out some key takeaways. Memory tips from these notes to help this stick.
Good idea. Okay, first, remember those creatine kinase levels? 50 to 100 times normal? That huge number is a massive clue for DMD.
Got it. High CK. And Gower's sign, that image of the child climbing up their legs, really visual sign of that proximal weakness.
Exactly. Also, firmly link the X-linked inheritance to why it's primarily boys. That explains the pattern and highlights why genetic counseling is so important.
Right. X-linked inheritance. And maybe that's slightly strange finding the muscle wasting overall, but those enlarged calves, the pseudo-hypertrophy.
Yeah, that contrast is memorable. Big calves, weak muscles, and maybe the most crucial point for prognosis. While it starts as a muscle disease, the main drivers of mortality are the cardiac and respiratory complications. Shifts the focus of late-stage management.
Heart and lungs. Okay, super helpful. Wow, that was a really comprehensive run-through of Duchenne Muscular Dystrophy, all based on the revision notes you shared with us. We've covered the definition, the cause, the signs, diagnosis, management, prognosis, pulling out those key details.
Yeah, hopefully connecting the dots from the gene to the protein to the muscle damage and then the wider complications helps put it all together.
So for you listening, hopefully this deep dive has helped organize this information, highlighted what's most important, and maybe made revising this topic feel a bit less daunting.
And it leaves you with a thought, doesn't it? Thinking about those future developments like gene therapy, how might they truly change the landscape for managing conditions like DMD, moving beyond just managing symptoms, something to keep an eye on as you continue learning.
Definitely something to think about. A huge thank you again for sharing your notes and letting us dive into them with you. If you are prepping for the MSRA or similar exams, resources like the ones this likely came from are invaluable. You can find more info and revision materials over at pathomsra.com.
And don't forget, there are also excellent free resources out there to support your learning, like those at freemsra.com.
Thanks for joining us for this deep dive. Until next time, keep learning and keep asking questions.